Our next speaker today is a medical oncologist at Sunnybrook Health Center. I met him again in 2008. I was busy at that conference, wasn't I? And he actually is responsible, I believe, for part of my survivorship because in one of the meetings we had afterwards, he said to me, make sure that you take your medicine at night. And so I began taking my Sutent at night. The other thing he said to me is if something crops up, my attitude is go in, get it, and get it out and do it quickly, right? You say go after it, be aggressive. And so I credit you, sir, for me standing here today. Mr. Dr. Georg Bjarnason.
Okay, so I am going to speak about systemic therapy. I could easily speak about it for hours, so I'm only going to speak about a few aspects of it. And I'm going to focus on the impact of individualizing therapy. And at the end of the talk, I'm going to introduce you to some interesting information about immunotherapy that I think is going to have impact in RCC. So I don't think anything is okay. So here is an outline of all the therapies that you have all seen for RCC. Almost everybody in Canada receives either sunitinib or pazopanib at the outset, and after Sutent and Pazo are active, they generally receive either everolimus or axitinib. It is often appropriate in individuals where the tumor seems to be basically staying the same over time to simply keep an eye on it, you know. So often we observe over time before we offer any therapy. It's important to understand that even after individuals have had all the anti-angiogenic therapies, you know, Sutent, Pazo, everolimus, axitinib, it is often appropriate to see if some of the older therapies are actually also active. So we sometimes offer immunotherapy with interferon, and we often also try to offer chemotherapy. So as I said, I'm going to talk about Sutent individualized therapy, and I'm going to show you some of the arguments. We have had Sutent for about 7 years, and early on, all of us saw that relatively few patients were actually able to receive the higher dose of Sutent and actually stay on it for 28 days. And the other thing we saw was that if you ended up on 25 milligrams or 37 milligrams, often the therapy didn't seem to be quite as active. Then there was clear evidence that the higher the Sutent is in the body, the higher the activity. So it was evidence to aim for a higher dose, even if you were only able to receive it for a briefer time. The other thing we saw early on is that during the time you were actually off the therapy, we would often see an increase in the tumor. So it was an argument to be off the therapy for a briefer time. So after our sort of early experience, we started to individualize the therapy and simply aiming for everybody having a degree of toxicity as evidence of each individual having the optimal dose of therapy. So here are some data sort of highlighting the individual variability. All of these individuals have the same serum concentration of sunitinib, but as you can see, some of them are only receiving 25 milligrams, whereas others only end up having that serum concentration if they are on 75. So it's clear that you aren't able to offer everybody the same. These are our data that you're unable to see and don't know what happened here. This is a slide where we analyzed the serum concentration in 23 patients over time, and we saw that there was quite a significant inter-individual variation. So having had this early experience with sunitinib, I started to individualize therapy, and sort of our treatment strategy is basically explained here. We start everybody on the higher dose. We aim for them to be on the therapy for 28 days. If they are unable to be on the therapy for 28 days, instead of them going to a smaller dose, as we are told, we try to keep them on the higher dose, but we treat them for half the time. If there isn't any toxicity, we add extra days on the therapy for each and every individual until we see an early evidence of some toxicity. If they are unable to stay on the therapy for 14 days, we bring them down to on for 7 days, off for 7, and again individualize how many days they are actually on the therapy. We only go down to the 37 milligrams if they are unable to stay on the higher dose for 7 days. And we only go down to 25 if they are unable to stay on the 37 for 7 days. So anybody ending up on the smaller doses, there has to be clear evidence that they are unable to receive a higher dose. And as you can see here in 172 patients that we analyzed the outcome for, here are the side effects that are the argument for having to alter the dose and the schedule. It's important to understand that there is an inter-individual variability in who these side effects are, So every patient doesn't end up having all. And even though we say that we aim for grade 2 toxicity, we pretty well stop the therapy before there is any extreme toxicity. So actually, individualizing therapy is by far the best way to deal with any of these side effects that we see. So here is the outcome in these 172 patients. As you can see, far fewer patients ended up having to receive smaller doses as compared to the data from the literature, and only 7 patients ended up having to stop the therapy. Or I should say 7% ended up having to stop the therapy because of side effects. And obviously, if you aren't able to be on the therapy isn't able to achieve anything. So being able to stay on therapy is extremely important. And after we analyzed the outcome for these patients, these 172 patients, we had 62 patients who ended up on the 25 or the 37 dose, 72 patients who were able to stay on the higher dose, even though they could only stay on it for a briefer time. And then we had another group of patients who were able to stay on the full dose for 28 days with hardly any side effect. Interestingly, this group of individuals had a significantly inferior outcome. So the group where I ended up having to alter the dose and the schedule because they were actually having some side effects had a dramatically improved outcome. And there are similar data from several other studies. 185 patients from MD Anderson, they show almost exactly the same. 770 patients where they analyzed outcome depending on if they had any of the side effects, again improved outcomes in the individuals who had side effects, and another group of 520 patients that actually included all the patients on the Sutent interferon trial, which was the clinical trial defining Sutent as the optimal therapy. They saw dramatically improved outcomes when they analyzed this study in the group that actually had some degree of toxicity. Similar data, even though I will be unable to speak about that, for other similar agents, sorafenib, paso, and axitinib. The other interesting data we have, and I'm gonna ask Wally to try to point, because I'm not able to, is interesting imaging that here we are imaging patients receiving Sutent therapy. They were all receiving it for 28 days if they were able to. As you can see, we saw an improvement in the tumor on day 7. We saw improvement again on day 14, but as you see, after they had been off the therapy for 14 days, we saw an increase in the cancer. And so it's an argument to be off the therapy for a briefer time. Interestingly, in the group we were able to study when they had been on treatment for 14 days and for 28 days. Between day 14 and day 28, we saw hardly any impact on the cancer. On the other hand, we all understand that if you stay on the therapy between day 14 and 28, you become iller. So in some patients, all the benefit from the therapy has actually happened after you've been on the drug only for 14 days. The other interesting observation, and there are several studies now showing something similar, and there is evidence that we will be seeing something similar for sunitinib. We are in the process of asking that. These are data for patients taking an agent similar to sunitinib called sorafenib, individuals on the same dose, but as you analyze the serum concentration over time, it gradually goes down over time. And they also saw the therapy coming easier with fewer side effects. It's exactly the same that we often see in individuals who are on sunitinib. The therapy becomes easier. It's an argument. If we see an early increase on the CT scan, it's an opportunity to go to a higher dose. So it's important to individualize therapy at the outset. It's equally important to individualize therapy as you stay on the therapy. So having seen all of these data, we hypothesized that the inferior outcome in the group of patients who were able to receive Sutent for 28 days without any side effects is that they were basically underdosed, and that aiming for a degree of toxicity would be an opportunity to optimize the therapy for each and every individual. So we opened a study all across Canada where we are going to enter 110 patients. On this study, we basically individualized therapy as I explained, but in individuals where there isn't any toxicity, we try to treat them at a higher dose. And we treat them on the schedule that our imaging indicates is the optimal scheduling. So on 4/14 or 4/7. And I can show you some early data. We've entered 70 patients. We've analyzed data to some extent for 62. And as you can see here, for 68% of these patients, they have been able to receive a higher dose than if we simply offered Sutent the same way as we are told. As you see, 22% have been able to go up to either 62.5 or up to 75. These patients who are staying on the higher dose, but simply for fewer days, all of these patients, if we had applied ordinary criteria, would have been receiving the 37 dose. And as you can see, very few patients have ended up receiving either 25 milligrams or the 37. We also have some very exciting information about the activity of individualized therapy. This is obviously early on, but so far over 90% of our patients have either had benefit on the therapy, and as you can see, there is a dramatic inter-individual variability in how high a dose each of them is able to be on and for how long they can stay on the therapy. So there is, I see it as evidence that by individualizing and optimizing therapy for each and everybody, we are actually able to improve the outcome. So what? I think I'm over time. I was going to show you a few cases, but you know what? I'm going to flip through those, and I'm just going to show you a few slides about immunotherapy. Because I think all of you have heard about interferon, high-dose IL-2. These are the old immunotherapies, certainly had some impact, but we have a deeper understanding of how the immune system operates, and through that there are therapies coming that I think are going to have a dramatic impact in RCC and actually in any oncological illness. So basically the tumor, and you are, for some reason you're not seeing the whole humor there. The tumor has been able to inactivate the immune system. So these immune cells haven't been able to attack the cancer cells. But because we understand how that happens, they've now been able to come up with these antibodies, for example, this agent from BMS, that inhibits the ability of the tumor to inactivate the immune system so that these immune cells are actually able to attack the tumor cells. So the early evidence is extremely encouraging in RCC and in several other cancers. Here are some of the early data, sort of showing data similar to what we saw with high-dose IL-2 early on, but where we basically see activity, but really the important thing is that even after you stop the therapy, the tumor stays under control. So I think these therapies are going to have a dramatic impact. There are several agents that that have this activity. Several of these agents are being tested in RCC, and so we will see several trials where we will try to optimize the activity of immunotherapy by adding immunotherapy to all kinds of other therapies. All of this is going to take some time, but the early data from the earliest clinical trials are imminent, and I think we're going to see FDA approval, hopefully Health Canada approval for some of these agents pretty soon. This is only to show you that with our deeper understanding of the immune system, there are several of these things on the outside of the immune cells that we are able to aim our therapy at. It's important to understand that it's actually therapy for the immune system. It isn't therapy for the tumor. It's therapy for the immune system, so the immune system is able to attack the tumors. So only a final slide. I think everybody on systemic therapy should be asking themselves, am I receiving individualized optimal therapy? I think it can have a dramatic impact. I think it's extremely important, and I talked about stereotactic in the patient cases that I was unable to go through. My colleagues speaking after me will speak about that. It's extremely important, and I think is being underutilized. And as I said, I think these new immunotherapies are going to have a significant impact for RCC. Thanks a lot.